Spinal cord stimulation, or SCS, is a breakthrough therapy that has transformed the management of chronic neuropathic pain. Originally inspired by pacemaker technology and the gate control theory of pain, SCS involves implanting electrodes in the epidural space of the spinal cord. These electrodes deliver electrical pulses to modulate pain signals, offering relief for patients who have not responded to conventional treatments. Over the decades, SCS devices have evolved, now featuring advanced leads and programmable generators. In this video, we'll explore how SCS works, its mechanisms, and its clinical applications for both peripheral and central neuropathic pain. Journey of spinal cord stimulation began in the 1960s, building on the gate control theory that suggested pain signals could be modulated by electrical stimulation. Early SCS devices were simple, consisting of an electrode and a pulse generator. The first successful use in patients was reported in 1967, and since then the technology has advanced significantly. Today, SCS is a well-established intervention for chronic pain with various stimulation modes and improved safety profiles. Understanding this history helps us appreciate the progress and the scientific foundation underlying modern SCS therapy. SCS works by delivering electrical pulses to the dorsal columns of the spinal cord, targeting large-diameter non-nociceptive A beta fibers. This stimulation modulates the transmission of pain signals, effectively closing the gate to nociceptive input. The electrical pulses can travel both endodromically and orthodromically, influencing not only local spinal circuits but also higher brain centers involved in pain perception. The result is a reduction in pain intensity and an improvement in quality of life for many patients suffering from neuropathic pain. Neuropathic pain is a complex condition that can arise from damage to either peripheral or central components of the nervous system. Peripheral neuropathic pain, PNP, is often seen in conditions like complex regional pain syndrome, CRPS, failed back surgery syndrome, FBS, and diabetic neuropathy. Central neuropathic pain, CNP, on the other hand, typically develops after events such as stroke, spinal cord injury, or multiple sclerosis. Both types share features like spontaneous pain, allodynia, and hyperalgesia, but differ in their underlying mechanisms and sites of injury. Peripheral sensitization occurs when injury or inflammation leads to the release of mediators that lower the threshold of nociceptors, making them more responsive to stimuli. This process involves changes in ion channel expression and activity, resulting in heightened sensitivity to pain. Even normally non-painful stimuli can become painful, a phenomenon known as allodynia. Peripheral sensitization is a key feature in conditions like CRPS and diabetic neuropathy, and is an important target for therapies like SCS. Central sensitization refers to the increased excitability of neurons in the spinal cord and brain, leading to amplified pain signals. This process is driven by the release of neurotransmitters like glutamate and substance P, and the activation of receptors such as NMDA and AMPA. Central sensitization is responsible for persistent pain and exaggerated responses to stimuli, and is a common feature in both peripheral and central neuropathic pain. SCS aims to counteract these changes by modulating neural activity at multiple levels. Glial cells, including microglia and astrocytes, play a significant role in the development and maintenance of neuropathic pain. After nerve injury, these cells become activated and release pro-inflammatory cytokines, further sensitizing neurons and perpetuating pain. SCS has been shown to reduce glial activation, thereby decreasing the release of these inflammatory mediators and contributing to pain relief. This highlights the importance of targeting not just neurons, but also supporting cells in pain management. Gate control theory of pain, proposed in the 1960s, revolutionized our understanding of pain modulation. According to this theory, the activation of non-nociceptive fibers can inhibit the transmission of pain signals at the spinal cord level, effectively closing the gate. SCS leverages this principle by stimulating large-diameter A beta fibers, which in turn activate inhibitory interneurons and suppress pain transmission. This foundational concept remains central to the mechanisms of SCS-induced analgesia. Segmental inhibition is a key mechanism by which SCS achieves pain relief. By increasing the release of inhibitory neurotransmitters like GABA in the spinal cord, SCS dampens the excitatory transmission between nociceptive fibers and spinal neurons. This process reduces the overall excitability of pain pathways, leading to a decrease in pain perception. Clinical and experimental studies have confirmed the importance of segmental inhibition in the effectiveness of SCS. Recent research has uncovered the involvement of endocannabinoids and endogenous opioids in SCS-induced analgesia. Activation of cannabinoid receptors and opioid receptors in the spinal cord contributes to long-lasting pain relief. These systems work alongside traditional neurotransmitters to modulate pain at multiple levels. The discovery of these pathways has opened new avenues for enhancing the effectiveness of SCS and developing complementary therapy. Descending inhibition refers to the brain's ability to suppress pain signals traveling up the spinal cord. SCS can enhance this natural pain control system by promoting the release of neurotransmitters like noradrenaline and serotonin from brainstem regions. These chemicals modulate spinal neurons and reduce pain transmission. The involvement of structures such as the locus coeruleus and the rostral ventromedial medulla underscores the complex, multi-level action of SCS in pain modulation. Beyond the spinal cord, SCS can influence higher brain centers involved in pain perception and emotion. Functional imaging studies have shown that SCS alters activity in regions such as the thalamus, somatosensory cortex, insula, and anterior cingulate cortex. These changes not only reduce pain intensity, but also improve mood and cognitive aspects of chronic pain. This highlights the holistic benefits of SCS, addressing both the sensory and emotional dimensions of pain. Spinal cord stimulation is widely used for peripheral neuropathic pain, especially in conditions like CRPS, FBSS, and diabetic neuropathy. Clinical trials have demonstrated significant pain reduction and improved quality of life for many patients. SCS is often considered when other treatments have failed, and its use is supported by guidelines from major neurological societies. However, not all patients respond equally, and careful patient selection is crucial for optimal outcomes. Use of SCS for central neuropathic pain, such as that following spinal cord injury, is still under investigation. While some case studies and preclinical research suggest potential benefits, the evidence is not yet robust enough for widespread clinical adoption. Challenges include the complexity of central pain mechanisms and the risk of complications in spinal cord injured patients. Ongoing research aims to clarify the role of SCS in this challenging patient population. Modern SCS devices offer a range of stimulation parameters, including conventional tonic stimulation, high-frequency stimulation, and burst modes. Each mode has unique characteristics and may be better suited for different types of pain. For example, high-frequency stimulation is often used for mechanical allodynia, while low-frequency modes may be more effective for heat hyperalgesia. Personalizing these parameters is key to maximizing pain relief and minimizing side effects. Clinical trials have shown that SCS can provide significant pain relief for many patients with peripheral neuropathic pain. For example, in CRPS and FBSS, SCS has been associated with marked reductions in pain scores and improved functional outcomes. However, response rates vary, and some patients may not experience sufficient benefit. Ongoing studies continue to refine patient selection criteria and optimize stimulation protocol. Like any medical intervention, SCS carries potential risks and side effects. These include device-related complications such as lead migration, infection, and hardware malfunction. Some patients may experience discomfort from the implanted device or develop rare complications like epidural fibrosis. Careful surgical technique, patient monitoring, and prompt management of complications are essential to ensure safety and effectiveness. Not all patients are suitable candidates for SCS. Careful evaluation is necessary to identify those most likely to benefit, taking into account the type and duration of pain, previous treatments, and overall health status. A trial period with temporary stimulation is often used to assess response before permanent implantation. This approach helps maximize the chances of success and minimize unnecessary procedures. Research into SCS continues to evolve, with ongoing studies exploring new stimulation patterns, device technologies, and patient populations. Advances in imaging and neurophysiology are helping to unravel the complex mechanisms of pain and identify biomarkers for treatment response. The ultimate goal is to develop more effective, personalized therapies that provide lasting relief for patients with chronic neuropathic pain. Professional organizations such as the European Federation of Neurological Societies and the National Institute for Health and Care Excellence have issued guidelines for the use of SCS in neuropathic pain. While recommendations are generally positive for conditions like CRPS and FBSS, they remain cautious for other indications due to limited evidence. These guidelines help inform clinical practice and ensure that SCS is used appropriately and safely. Summary: spinal cord stimulation represents a powerful tool in the management of chronic neuropathic pain. Its mechanisms involve a complex interplay of spinal, supraspinal, and cortical processes, offering relief for many patients who have exhausted other options. While challenges remain, especially in central neuropathic pain, ongoing research and technological innovation promise to expand the reach and effectiveness of this therapy. As our understanding deepens, SCS may become an even more integral part of pain management in the future.